Good afternoon, everyone. This is Christine at Health Current, and thank you for joining us for the program year 2020 document retention webinar. This presentation is provided through a shared commitment between Access, Health Current, and Myers and Stouffer to increase participation in the Medicaid Promoting Interoperability PI program. Just a few logistical reminders. Today's webinar is being recorded and will be posted to the Health Current and Access websites. We encourage you to use the chat box for questions or comments throughout today's presentation. Just a reminder to please include a name, practice, or organization, and please do not include any confidential information such as patient health information or PHI. Just a reminder that all lines will be muted, and I will introduce Connie Ide, our Director of Programs, who will introduce today's presenter. Connie, are you with us?
I am, Christine. Can you hear me?
I can, thank you.
All right. We're very lucky today to have Priscilla Clark as a senior accountant with Myers and Stouffer, a certified public accounting firm, which specializes in federal and state Medicare and Medicaid programs, as our presenter. We're very lucky to have her. So Priscilla, please proceed with your presentation.
Thank you, Connie. Today, as has been already stated, we will be discussing Program Year 2020 documentation retention. For Stage 3, the learning objectives during today's presentation: understand what documentation must be submitted for Program Year 2020, understand what information must be contained in the documentation for each requirement, and then also to learn just common audit findings to make sure that your documentation that you have will not result in an audit finding. So let's discuss the meaningful use requirements first. So for meaningful use, all EPs are required to attest to Stage 3 of meaningful use for Program Year 2020. All EPs must have a 2015 edition certified electronic health record technology implemented. The EP must maintain at least 80% of all unique patients' data in the CERT. The EP must perform at least 50% of all encounters at locations with CERT. There are 8 objectives and the related measures must be met. Underneath those 8 objectives, there are 5 objectives that are called percentage-based measures, and then 3 objectives are called yes-no measures. If exclusions are selected, the EP must meet the exclusion criteria, and then the EP must report on the minimum required number and type of eCQMs. For Program Year 2020 meaningful use reporting period length, for the PI reporting period, it should be 90 days for all EPs, and that reporting period must be within calendar year 2020. For electronic CQMs, the reporting period is 90 days for all EPs and must be within calendar year 2020. So let's go over some definitions of the documentation terms. EPs are required to upload documentation for each measure. The following slides describe the documentation required for each measure. So it's important you keep these 3 definitions in mind. For standard documentation, there are 2 types of standard documentation. There's the yes-no standard documentation and then the percentage-based standard documentation. Sometimes there is additional documentation. The EP must submit standard documentation and the additional documentation listed for that measure. And then for when we mention alternative documentation, we're referring to the EP having the option to submit alternate documentation in lieu of the standard documentation. As you can see, this is just a broad table overview of a Stage 3 objective. In the first column, you can see we rank each objective 1 through 8, which is how CMS labels them. Then in the second column, we have the objective name. In the third column, we have the type of measure. Is it a yes, no, or a percentage-based measure? In the fourth column, we have what documentation is required. And throughout a lot of this, we either reference a webinar, which is in the link is in the last column. So when this presentation is sent out to everyone after today's webinar, you can easily click on the hyperlink in the last column to look at previous webinars that were conducted for Program Year 2020 that have more specific details. For Objective 1 for security risk analysis, you can see that it says for you to look at the SRA webinar. For the second objective, electronic prescribing, it is a percentage-based measure, and so we're telling you that the provider should be submitting the percentage-based standard documentation. But you can also look at the webinar. If you just go through each of those objectives, you will see what type of documentation will be required, and we will dig in further to what type of things we look for on that documentation throughout this presentation. So this is a Stage 3 compliance summary table, and so it does again list all the objectives, and then it tells us whether the EPs have to be in compliance with the different 8 objectives. As you can see, the providers have to be in compliance for all 8 objectives. In that middle column, which is the 4th column, it talks about the EP state exception, and it identifies whether there's an automatic exception for the different providers. If we move down towards the bottom of the table for Objective 8, which is the public health objective, you can see for the syndromic surveillance reporting row, so that is the 4th row from the bottom, it identifies that there is an exception for Arizona EPs, which we will discuss a little bit later in further detail. But that's just an automatic exception for the EPs in the state of Arizona for syndromic surveillance only. Please keep in mind for Objective 8 for the Immunization Registry, which is 1 row up, the Immunization Registry reporting requires bi-directional data exchange in order to meet the measure. This is another table just listing out the exclusions for Stage 3. As you can see, there can be multiple exclusions depending on the measure. For Objective 1, there are no exclusions allowed for any providers. For Objective 2, electronic prescribing, there are 2 different exclusions. You can have, the provider can have less than 100 permissible prescriptions during that ME reporting period, or the second exclusion is that they have less, they do not have any pharmacies within 10 miles of their practice. For the 3rd objective, it's clinical decision support. There is only an exclusion for Measure 2, which is that the provider has less than 100 medication orders. So as you can see, this is just a brief overview of the different exclusions allowed for different objectives. And as we go throughout this presentation, we will discuss the documentation requirements for each of these measures and any exclusions that are claimed. So let's first discuss the 2015 Edition CEHRT, which is a requirement for all providers for program year 2020. EPs must use the 2015 Edition CEHRT for program year 2020. The 2015 Edition CEHRT did not have to be implemented on January 1st, 2020. The CEHRT, however, the CEHRT must be implemented by the first day of the PI reporting period, and then the CEHRT must be certified by ONC as a 2015 Edition product by the last day of the PI reporting period. For example, the 2015 edition may have been implemented by the practice before the start of the PI reporting period, even though the product is still pending ONC certification. However, the certification must be approved by ONC by the last day of the PI reporting period. You can also see the ONC website to learn when various CEHRT products were certified. That is another hyperlink that you can click on just to gather more documentation. So the documentation requirements, what we look for. CEHRT documentation should include the date the 2015 edition CEHRT was implemented, the edition number, and the practice name. Examples of this documentation can be a CEHRT contract, a vendor letter, or other things, as long as they identify those 3 requirements. So the date of the 2015 edition CEHRT being implemented, the edition number, and the practice name. This is an example of a documentation that would potentially be acceptable. We want to make sure you can identify those 3 items: the date that it was implemented at the practice, version number, and as you can see in this letter, there's a lot of wording, but there is specific parts where it says to meet the 2015 edition PI objectives. So it's referring to 2015 edition CEHRT. Towards the bottom, you can see the version number. You can see the different information that we need. And then also you want to make sure your practice name is listed on whatever documentation you submit. Moving on to general requirements documentation, there are 2 general requirements that we will discuss. The first one is that the EP must maintain at least 80% of all unique patients' data at locations with CEHRT in the CEHRT. The second general requirement is that the EP must perform at least 50% of all encounters at locations with CEHRT. EPs who practice in multiple locations must have 50% or more of their patient encounters during the PI reporting period at a location or locations equipped with CEHRT. So the documentation for general requirements, the provider should submit a detailed encounter listing for the reported 90-day PI reporting period in Excel containing the following fields: the patient name or unique identifier, the date of service, the date of birth, the location name, and identify which patients or encounters do not have data maintained in the CEHRT if they were seen at a location that has CEHRT. This is just an example of a table in Excel that could be submitted. You want to, again, make sure those requirements listed on the previous slide are listed in the Excel file. A lot of practices, when pulling different Excel files out of their systems, may have a lot more information than those few things that we look for, and that's okay. Just make sure at a minimum they have those things that we listed on the previous slide. Keep in mind that additional documentation to validate the accuracy of the general requirement patient detail may be requested after reviewing your Excel document. Moving on to percentage-based documentation, keep in mind that there are 5 objectives that are considered percentage-based, and unless otherwise specified, submit the CEHRT dashboard for all percentage-based measures. The CEHRT dashboard should reflect the correct PI reporting period, include the provider name, reflect all percentage-based measures, and match the attestation. Now, when we talk about reflect all percentage-based measures, keep in mind that the numerator, the denominator, and the measure percentage should be showing on those reports. Keep in mind that in certain situations, if you are not able to produce a CEHRT dashboard, you can reach out to Access Team and ask them if a non-CEHRT generated report can be submitted. Once you receive approval from them for that, you'll be able to submit that report. When it comes to the numerator, there are certain situations that if an EP used opt-out patients to meet the measure threshold for Objective 5, additional supporting documentation is required. Further detail regarding those opt-out patients is discussed later in this presentation, and this only affects Objective 5 numerator. And then also, if the EP practices at multiple locations with CEHRT, they should submit the CEHRT dashboard reports for all locations and add the MU data together when attesting. So you want to add those numerators and those denominators together for each measure. If attesting to an exclusion for a measure, the CEHRT dashboard may be utilized to support meeting the exclusion criteria for certain measures. If the exclusion is not supported by the CEHRT dashboard, alternate documentation is required. Options of alternate documentation is to provide supporting documentation other than the CEHRT dashboard that demonstrates the EP meets the exclusion. So for example, when it comes to clinical decision support objective, there's a measure called drug-drug and drug allergy, and the exclusion for that is the provider has less than 100 medication orders. So in that scenario, you could just submit the CEHRT dashboard to support the provider meets that. Or you could potentially have some other documentation in your CEHRT that is allowed. This is an example of percentage-based documentation. As you can see, it lists each objective, and over to the right-hand side, it shows the numerator over the denominator in the far right column, and then 2 columns to the left, it shows that threshold that's required, and then right in between that is that score. So what was the actual percentage for the provider? So it's showing those things. In the top right-hand corner, you can see that it identifies that PI reporting period, so that 90-day window, because we're going to need to see that on any reports that are submitted. And then make sure that your provider name is listed on this report so we know the numerator and denominator numbers were pulled for that specific provider. Moving on to Objective 5, which is patient electronic access. We have presented a webinar for Program Year 2020 a few months back. So at the very bottom of the screen, you can see that there is a hyperlink that allows you to go in and look at that webinar for Program Year 2020, and it holds a lot more information and goes into a lot more detail than we will be covering during this presentation. So if you do have any questions or anything, that is always a great source to go to. So first, let's discuss Measure 1 for this objective. So you need to submit the percentage-based standard documentation that was discussed on slide 19, and we showed you an example of it. And also you should include a copy of instructions provided to patients on how to authenticate their access through the API. Examples are included on the following slides that we'll go over. The third thing that we need is a copy of information given to patients on available applications that leverage the API. And then moving on to measures 1 and 2, if patients that opted out of the patient portal are included in the numerator for either measure, an opt-out patient audit log must be submitted and include the following. It must include the patient name or unique identifier, the date of service, the date of birth, confirmation the health information was timely made available, and finally, confirmation the patient opted out of participation. Keep in mind that this does not apply to all providers. So moving the first half of that slide about measure 1 only, you need to submit the percentage-based documentation. That numerator and denominator, if it helps you to meet the minimum threshold required for this measure, for measures 1 and 2, then go ahead and submit that percentage-based standard documentation. But there are certain providers that don't meet that minimum threshold, and CMS allows some leniency in allowing providers to add in patients that chose to opt out of using that patient portal. And that applies to measures 1 and 2 if you don't meet that minimum threshold. And again, at the very bottom of the slide, it shows that patient electronic access webinar, which goes into even more detail about opt-out patients if you're confused at all. And we can also answer questions at the end of this presentation regarding opt-out patients if you want to discuss that. This is an example of how to authenticate access. So the practice confirmed that the information above is emailed to every patient immediately after the visit. And so this MyChart is connected to the practice's CERT via an API, so it is supporting that the patient was given that access to the API and their patient data via an application programming interface, which is a requirement for Program Year 2020 underneath Objective 5. Another example is the provider needs to show that they provided available applications to each patient that came in, and so this document was given to each patient as they left the office, and so it's an example of available applications that the patient can use, and this is included in the email sent to the patient on the previous slide. So practice confirmed that these 2 documents were sent to each practice after the patient's visit, and so this shows that they were actually showing the patient what applications were available and that they had access to it via an API. This is another example of just available applications. Apple Health is connected to Care Notify via an API, and the practice had to confirm that for us. And then this information was distributed to patients via email when they came in and were seen by the practice. This is an example of an opt-out patient audit log. As you can see, there are multiple columns. This should be submitted in Excel during attestation, just to list each patient that you want to include as an opt-out patient. This is only necessary if you're including those opt-out patients in your numerator. If you're just taking the numerator and denominator from your CERT dashboard and you meet that minimum threshold, this is not a necessary step. This is only when you're adding those opt-out patients to the numerator. So the opt-out patient audit log must include only patients that had a visit during the VI reporting period, and additional documentation to validate the accuracy of that audit log may be requested if selected for post-payment audit. For example, a copy of the document the patient signs stating he or she opts out of the patient portal. So if you're saying, so we might randomly select patient 115 and say we would like to see that form where the patient signed that they wanted to opt out. Moving on to Objective 6, Measure 3, Coordination of Care through Patient Engagement. We also done a webinar on this objective, so if you want to know additional information, we do have that resource at the bottom of this slide where you can go to that link and look at that webinar. This is a percentage-based standard. If you'll need to submit that appropriate documentation for percentage-based, and look at slide 19, which lists all the requirements. There is an additional component of this, and you will need to upload an explanation of what patient-generated health data is being utilized and how the CERT is capturing that data. Additional documentation may be requested after review of the provider's methodology. So that's the percentage-based documentation that we've discussed. And now we're going to move on to yes-no standard documentation. So for the standard documentation, documentation to support yes-no measures must be submitted. The CEHRT dashboard alone cannot be used to support these measures. The documentation should include screenshots from the CEHRT or vendor letters to support the applicable functionalities were enabled or the actions required were performed. So for each document, we're going to look at, does the document include a provider and or practice name? Does it reflect results for the measure? Is it clearly legible? And does it reflect the date the requirement was met? Now we're going to discuss the different dates and what dates should be listed on each document depending on the yes-no measure. So there are different dates that are appropriate depending on that yes-no measure, and there are 3 yes-no objectives. So for objective 1, the security risk analysis, just keep in mind that the SRA must be completed on or after the end of the PI reporting period and no later than December 31st, 2020. If you go back up to one of the first slides in our presentation, there is a link to the SRA webinar if you want to look at a few examples of ones that we've put together in the past to make sure your SRA is dated appropriately. Every provider must submit the SRA that was completed at their practice, and it must be completed between the end of the PI reporting period, but no later than December 31st, 2020. Moving on to objective 3, which is the clinical decision support rule in drug-drug and drug-allergy interaction checks. It should reflect the date the requirement was met during the PI reporting period. So you have 90 days where you need to show that those requirements were turned on in the system. The third objective, which is objective 8, is the public health measures. And the documentation should reflect the date the EP active engagement option 1, 2, or 3 milestone was achieved. Later on slide 4, you can look at the appropriate date for each active engagement option. So for objective 1, here's a few examples that we can go over just to show which ones, when you need to complete your SRA. So for example, in program 2020, for all these examples, the first provider had a PI reporting period of January 1st through March 31st. So the provider must, or the practice, because usually it's the practice completing these SRAs, must complete the annual SRA between March 31st, which is the last day of the PI reporting period, but before or on December 31st, 2020. The second example listed is a provider who has a reporting period of October 1st through December 29th. Therefore, the only appropriate SRA date would be December 29th through December 31st. The next example is for June 1st through August 29th is the PI reporting period. So therefore, the practice appropriate date on that SRA would be August 29th through December 31st, 2020. And the last example is a provider who has a reporting period of October 3rd through December 31st. The only appropriate date that would be sufficient and that would pass the requirements is if that SRA was completed on December 31st, 2020. The SRA report must include the completion date, the month, the day, and the year. Keep in mind that practices can start updating their SRA earlier in the year, but they need to make sure that they finish it on that December 31st and review it and make sure to put that date on there of the last day that it was reviewed. But again, it can only be complete, it has to be completed by December 31st, 2020. Moving on to objective 3, measure 1, documentation for clinical decision support. That document should include the provider and or practice name, 5 CDS interventions related to 4 or more electronic CQM that were enabled. The documentation should be clearly legible and should reflect the date the requirement was met during the PI reporting period. For example, screenshots from the CEHRT or vendor letters to support the 5 CDS were enabled. Keep in mind that 4 of those CDS will need to relate to those CQMs. Here's an example of the CDS documentation. You want to make sure that the requirements listed on the previous slide are in the document that you submit. And so as you can see, we've redacted the provider name, but that provider name or some way you need some type of name, like the practice name on the document, on the screenshot, to support that this screenshot ties to your practice. It can be the specific provider, it can be the practice name, something along those lines. You want to make sure that the date is shown in the screenshot. As you can see in the middle of the screenshot, it does say the date/time it was taken, which was December 10, of 2019. That would be sufficient for a program year 2019 screenshot, but it would not be sufficient in 2020. So you want to make sure all those requirements on slide 32 are met in the documents that you submit. This is another example. This is an example of a vendor letter that was written listing the CDS rules that were implemented during that PI reporting period. But again, when you reach out to that vendor, you want to make sure they list that 5 CDS rules were turned on, that 4 of them relate to CQM measures, or if there's a way to tie them to CQM measures. And then you also want to make sure they reflect that correct PI reporting period. Other types of documents can support CDS rules as long as the documentation supports 5 CDS rules related to 4 or more CQMs that were implemented during the PI reporting period. System settings from during the PI reporting period that demonstrate functionality was enabled prior to the period and cannot be disabled. That would be sufficient as well. So we can see additional information on this CDS tip sheet. And so when you click on that hyperlink, it takes you to a CMS tip sheet that just goes through the more clinical decision support rules and provides more information on the requirements and the details of those clinical decision support rules that the practice implements. So for Objective 3, Measure 2, documentation for drug-drug and drug allergy interaction checks, the documentation should include the following: the provider and or practice name, that drug-drug and drug allergy interaction checks were enabled. It should be clearly legible, and it should reflect the date the requirement was met during the PI reporting period. Examples of this is screenshots from the CEHRT or vendor letters to support drug-drug and drug allergy interaction checks were enabled. So there is an exclusion for drug-drug and drug allergy. The exclusion is if EP writes fewer than 100 medication orders. So examples of appropriate documents for this would be the first potential document is a CEHRT dashboard, which shows that the EP wrote fewer than 100 medication orders during the PI reporting period. If you are submitting a CEHRT dashboard for support of the exclusion, make sure that they list all the requirements that are needed as we identified previously on slide 21. The second type of documentation would be provide supporting documentation other than a CEHRT dashboard that demonstrates the EP has fewer than 100 medication orders. Here's an example of drug-drug and drug allergy documentation examples. So just make sure it has all those things listed on that previous slide. The provider or practice name, or maybe another employee, front desk employee of the practice who signed into the system and is taking these screenshots. You want to ensure that the documentation is dated appropriately. So this screenshot supports that the provider had drug-drug interactions enabled during the PI reporting period, so it has that electronic prescribing interaction checking for medication. So if potentially that means in your system, if that's checked, it's going to pop up and say, hey, you have a drug-drug interaction. But just make sure all those things listed on the previous slide are shown in this. So one example of the screenshot could include the toolbar on the bottom right of the screen to show the date the screenshot was taken. A lot of time practices will just screenshot the necessary component showing it was turned on, but not when it was turned on or when that screenshot was taken. So keep in mind that you need, when you take a screenshot, you want to show that date the screenshot was taken in the bottom right-hand corner. And that date needs to be within the PI reporting period. Here's another example showing that the patient has medication allergies. Sometimes we see practices will submit 2 different screenshots, one to support the drug-drug interaction working and then one to support the drug allergy interaction is checking. But just make sure every screenshot shows provider practice name and that date it was taken and any other requirements listed on slide 36. So for Objective 8, documentation for public health reporting, documentation must prove that the EP's level of active engagement was met, and the documentation must be dated to show when the active engagement, option 1, 2, or 3 milestone was achieved. So depending on which active engagement option you're in, that date could potentially change for what is sufficient. For active engagement option 1, the completion date can occur before calendar year 2020 if the EP has not progressed. and is still in active engagement option 1, but no later than 60 days from the start of the PI reporting period. Active engagement option 2, the completion date can occur before calendar year 2020 if the EP has not progressed and is still in active engagement option 2. For active engagement option 3, the completion date can occur before calendar year 2020 if the EP is still in active engagement option 3 during that calendar year. So documentation submitted should include the provider and or practice name. It should reflect the EP's level of active engagement. It should be clearly legible, and it should reflect the date the requirement was met. And those dates are identified in slide 40, depending on what active engagement option they are in. Examples of supporting documentation to meet this measure is on the upcoming slides. First, for exclusion documentation. So for exclusion 1, additional documentation, you will need to explain and document why the EP does not or is not required to collect the data for the applicable measure in their jurisdiction. If you look at the webinar, which we referenced at the beginning of this presentation for public health reporting, you'll see what requirements are there for exclusion 1 for each of the different measures, because there are 5 measures underneath Objective 8. Then the additional documentation for exclusions 2 and 3, an EP must complete 2 actions in order to find available registries or claim that exclusion. The EP will need to determine whether his or her jurisdiction endorses or sponsors a registry, and 2, determine whether a national specialty society or other specialty society with which he or she is affiliated endorses or sponsors a registry. Keep in mind that exclusions for Measure 2, which is syndromic surveillance, and Measure 3, which is electronic case reporting, does not require any documentation because the EPs in Arizona are automatically given those exclusions. Another example of when discussing additional documentation for exclusions 2 and 3, keep in mind that there are 2 things that you have to do. A lot of EPs do get tripped up or are confused on this, but you need to determine whether the EP has a jurisdiction, what that jurisdiction is, and whether there's a registry inside of it. And so you need to potentially, an example of how to provide that documentation to the auditors is to write up a letter on the practice letterhead explaining the reason or steps taken to determine why the EP meets the exclusion. So why is there no registry in your jurisdiction? Where did you look? Did you reach out to anyone to ask if there was a registry available? Things along those lines, just documenting those steps ahead of time so that you know that you're going to be able to pass and meet those exclusions. This is an example of immunization documentation. So as you can see, it's from the Arizona Department of Health Services, and they're confirming that there is an EP for this specific practice that meets the requirements and was submitting data at a certain date. Again, you want to ensure that the documentation that you submit to support immunization includes the items listed on slide 41, the provider, practice name, a date on there. Make sure all those requirements are listed so that they will be accepted. Here's another example. This is an email from someone who works for the Arizona Department of Health who confirmed with the provider that they were registered with that, with the immunization registry. So there are multiple examples. The previous one was on a letterhead and was very official looking, but then this is an example of a potential email that could be sent to a provider. And this email would also be sufficient if you forward that on when you are testing or when the auditor requests additional documentation. This is an example of syndromic surveillance documentation, and this is on an official letterhead, just explaining that the provider, or in this case, the hospital, meets the syndromic surveillance data and submitting that data. So keep in mind that there are multiple ways to meet these different measures. It can be exclusions. It can be, you can be in 3 different active engagement levels, 1, 2, or 3, depending on if you're registered, whether you're testing to submit data to the registry, or if you're actually submitting real live data. This is an example of a public health registry. And so this is a provider that was submitting data, and so it's just an official letter that was sent to them. But again, you want to ensure that you have that date listed when you'll start to submit data so that it meets the active engagement state requirements. So just make sure you're referring back to this presentation as you're looking through the documents that you're going to submit to make sure you meet all those things that are listed, because if there is something missing, then the person reviewing your attestation may be reaching out to you to request additional documentation. Then there's the clinical data registry. So this is an example from DARTnet, which is a clinical data registry that providers can submit data to if they're registered. So if you are already submitting data to this type of registry to DARTnet, make sure to go in and check and see what type of documentation you have. But again, on slide 41, it mentions it needs to show a date. Make sure that data is appropriate. It needs to show the provider or practice name. It needs to show what level of active engagement you're in. Are you registered? Things along those lines. What are you doing with that registry? This is just a summary of Objective 8, just walking through what type of documentation might be appropriate. In the far left-hand corner, it talks about the documentation needed for registration. And so there's two different options there. It can be email confirmation from ADHS, Public Health and ePortal, maybe like an email confirming that you're registered, that you're submitting data currently, or you're in the testing phase, or it can be a screenshot in the ePortal that shows that you are submitting that data electronically. It can also be an email letter from ADHS with the status of where you're at. So if you don't have any documentation, go ahead and reach out to ADHS and request that information of what active engagement you're in and how long you've been in that. As you can see at the bottom of this slide, there is another link that takes you to the ADHS Public Health webinar. And for that webinar, there are contacts listed. There are more examples listed of different documents that would be acceptable and who you can reach out depending on what registry you need information on. In the second column, it shows the testing and validation documents that might be appropriate, email communications with ADHS, onboarding meeting notes, acknowledgments and messages received for testing, or an email or letter from ADHS with the status. Keep in mind that all these documents that are being mentioned, they still have to identify those requirements that are listed on slide 41, provider or practice name, the date that you started, and the level of active engagement. And that date still needs to be appropriate depending on what active engagement option you're in. The last column shows production, so you're actively submitting data to those registries. So email communication with ADHS when the EP is in production. Production acknowledgments and messages received. Submission reports or email or letter from ADHS with the status. So those are some other options for production of data. So let's move on to electronic clinical quality measure documentation and what potential documents you can submit that would be appropriate. So EPs must attest to 6 out of the 47 available eCQMs for program year 2020. Out of those 47, there are 6 outcome measures, there are 27 high priority measures, and there are 14 remaining measures that are not identified as an outcome or high priority measure. So the first requirement for EPs, if relevant, at least one eCQM should be an outcome measure. So one of those 6 should be an outcome measure if one of the 6 outcome measures that are available for you to report on is relevant to your scope of practice. If there are no outcome measures that are relevant to your scope of practice, you would move down to priority level 2. If no outcome measures are relevant, at least one eCQM should be a high priority measure. Keep in mind, towards the top of this slide, it identifies that there are 27 high priority measures that you can report on. So if it's relevant to the provider's scope of practice, one of their 6 should be a high priority measure. However, if none of those high priority measures are relevant, then the provider would move down to priority level 3, and they should just report on 6 relevant measures if possible. Keep in mind that you must attest to 6 eCQMs. So even if, say, for example, that all 47 are not relevant to the provider's scope of practice, you would still need to report on 6 of them and show that you can report and submit them and pull that document out of CEHRT. At the bottom of this slide, you can see that there's a clinical quality measures webinar that was put together. So you can check that out if you want additional documentation after this webinar. So documentation required. You need to run an eCQM report from the CEHRT for the appropriate reporting period. you need to prove the eCQM data was calculated by the 2015 Edition CEHRT. So, for example, the report must show the CEHRT name or edition or screenshots demonstrating how that report was pulled from the CEHRT. So if you took a few steps to pull that report into an Excel file, and that Excel file doesn't show it was pulled from the CEHRT, you want to screenshot those steps you took to pull the Excel report. So it shows that you're pulling that Excel report out of the CEHRT. So the report that you submit for the eCQM, those 6 eCQMs you're reporting on, should include the following: the required number and type of eCQM, the numerator and denominator for each eCQM, the provider name, the proper reporting period, and for the proper reporting period, it should be 90 days for all EPs, and that 90-day period needs to fall within calendar year 2020. So all 4 of those things should be listed on your CQM report that you submit. Here's an example of that of the eCQM report. As you can see, it lists only a couple CQMs, but make sure that your report that you submit during attestation or during a post-pay audit lists at least 6 eCQMs that you attested to. This screenshot does show it's pulled directly from Epic, so that would be sufficient to support that you're pulling it directly from the CEHRT. You want to make sure that your 90-day ME reporting period is showing on this report. So everything from slide 51, those 4 things that are identified, you want to make sure that you can find it in whatever documentation you submit during attestation. So moving on to patient volume requirements. So we've covered the meaningful use requirements and what type of things we look for in each document. So now we're going to move on to patient volume and walk through some of those documents and what will be required and what we look for. For patient volume reporting period, the patient volume is 90 days for all EPs, and that reporting period must be within calendar year 2019. EPs must have a Medicaid percentage threshold greater than or equal to 30%. Keep in mind that it can be 20% threshold for pediatricians. However, that pediatrician would receive a reduced payment. The numerator is comprised of the total Medicaid encounters, not including CHIP, and then the denominator is comprised of all payer encounters, including Medicaid and CHIP. Keep in mind for the numerator, certain EPs are allowed to add the needy encounters to the numerator patient volume. And in a few slides, we'll discuss more in detail about the needy encounters and when those can be included. Medicaid encounter is a service on any one day to a Medicaid-enrolled individual regardless of payment liability. This includes zero pay claims and encounters with patients in Title 21 funded Medicaid expansions, but not separate CHIP programs. Providers attesting to Medicaid patient volume cannot be hospital-based. The hospital-based requirement is a provider must have less than 90% of their Medicaid patient encounters in an inpatient hospital, which is place of service 21, and emergency room, which is place of service 23, setting in a 12-month period in the prior calendar year. A provider is exempt from the hospital-based requirement if the provider practices predominantly at an FQHC RHC. So for the providers that you think might not have less than 90% of their Medicaid patient encounters in an inpatient hospital or emergency room setting, so try to make sure they fall beneath that 90%, and if they don't, then go and look, are they in FQHC, RHC, do you have to worry about that? Now, when discussing adding needy patients to the numerator, certain EPs are allowed to include them to the Medicaid patient volume. So you would have support having greater than or equal to 30% needy patient volume or 20% for pediatricians. So pediatricians are allowed to do this too, but keep in mind that would be a reduced payment, but you need to support that you have greater than or equal to 30% needy patient volume. For needy encounters, that includes the Medicaid patient encounters, the CHIP patient encounters, and patient encounters for services rendered to an individual on any one day on a sliding scale or that were uncompensated. If attesting to needy patient volume, you must meet the following definition, which is practiced predominantly, which that definition is a provider for whom the clinical location for over 50% of the EP's total patient encounters over a period of 6 months in the prior calendar year must occur at an FQHC RHC. So for a provider to include that needy patient volume in the numerator, they need to be able to prove that they were practicing predominantly. And again, this is an additional step that is not needed for a lot of EPs if they meet that 30% volume, only counting the Medicaid patients in the numerator. So this is just an option. If that provider doesn't meet that original 30% for Medicaid patients, they can potentially look into this option for needy patients if they're practicing predominantly. Patient volume requirements. When reporting patient volume, providers may choose to report individual patient volume or use the group's patient volume. Individual patient volume includes encounters rendered by providers applying for payment. And then group patient volume is providers may use the group's patient volume. In doing so, their patient volume must include all encounters from all providers in the group during the reporting period. So the providers have an option to attest to either individual patient volume or group patient volume. If a provider from a practice chooses individual patient volume, all other providers at that practice must also do individual patient volume. A group is defined as all locations and providers under a business entity. The single business entity can be linked by any one of the following: the multiple employer identification number, the multiple national provider identifier, or the multiple group access provider numbers. Documentation for patient volume. So there are two links on this slide. So for the first one is the Medicaid patient volume requirement, and necessary documentation is detailed in the report layout for Medicaid patient volume tip sheet. So it kind of just walks through those scenarios, and this is for providers who meet that 30% by just including Medicaid in the numerator. And these slides will be sent out after this presentation, so you can click on those links and look through that. We won't have time during this presentation, but just keep that in mind. If you want more details about patient volume, you can go to that report. The second one is the needy patient volume requirements and necessary documentation, which is detailed in the report layout for needy patient volume tip sheet. And that's the providers who can't meet that 30% with just Medicaid patients in the numerator. So then potentially they can add those needy patients to the numerator as long as they are practicing predominantly. So that's the report layout, just explaining what the patient volume should look like for that. So let's look at the other eligibility requirements. There's the physician assistant, so documentation to support a PA leads the practice. A PA is leading a practice under any one of the following circumstances. If the PA is a primary provider in a clinic, so for example, when there's a part-time physician and full-time PA, the PA would be considered as the primary provider. The second option is PA is a clinical or medical director at a clinical site or practice, or the PA is an owner of an RHC. Supporting documentation may be requested by Access if needed. So for any providers that are testing to this program, if they are a physician assistant, they're going to need to make sure they meet one of those three requirements. This is an example of PA-led documentation. So this is a letter from the practice just explaining how this provider meets the PA-led requirement. So we're going to now move on to just audit findings and what are some common things that are found during audit. So first, what happens during an audit? All providers that receive a Medicaid PI incentive payment could potentially be selected by Access for post-payment audit. If selected, Access post-payment analysts will conduct a thorough review of the documentation attached to the EP's attestation in EPIP to determine if it meets the program requirements. So keep in mind, as you're submitting documents in EPIP during attestation, go ahead and submit everything that you think would be needed to meet any of these requirements. That way, you're not a year down the road trying to look for all these documents. Just go ahead and submit them in EPIP, and so you know that they're there. Just make sure they meet all the documentation requirements that have been listed throughout this presentation. Access may have follow-up questions or make additional documentation requests. Documentation retention. All documentation to support meaningful use is required to be kept for a minimum of 6 years after the date of attestation. Transmitting patient health information. All documentation must be uploaded via EPIP. If assistance is needed, please contact Access. Do not submit PHI via unsecure email. and all documentation containing PHI must be transmitted securely. Here are some common audit findings. Failure to provide sufficient documentation for protecting electronic health information. Second is the CEHRT dashboard does not show the PI reporting period or EP name. Another is failure to maintain proper documentation and practice no longer has access to the CEHRT. Supporting documentation does not have the appropriate dates. And lastly, including data for the entire practice in the reported CEHRT report rather than data for the individual EP. Here are some resources that can be used, and we've put a lot of resources throughout the presentation for the different objectives. There are a lot of webinars that have been conducted and posted on the Access website, so these links will take you to the Access website. Definitely that bottom bullet says the Access website for webinars, FAQs on all Stage 3 requirements, along with other educational material to assist you with successfully attesting for the PI program. And this is where we do have a few minutes left, so if you have any questions, feel free to put them in the chat box, and I will answer those for you. And we'll give y'all just a few minutes to put those questions that you may have in the chat box. Again, this presentation will be sent out to everyone after the presentation is concluded, so you can have these as for your resources and as you're starting to attest for Program Year 2020. We will also spend a few minutes, unless someone has a question, I'm going to show y'all. We did put together a frequently asked questions document for y'all for documentation retention, and we also have a tip sheet for y'all just to help you as you're going through. You should be able to see on the screen. Oh, go ahead.
So, Christine, do we have any questions in the chat box?
No, there have been no questions that have come through just yet, Connie.
Okay, perfect. Then Priscilla, why don't you go ahead with what you're going to go through your tip sheet.
Thanks, Connie.
I apologize, Priscilla. There is a question. Actually, a couple are starting to roll through. So one of the question is, when is the last program year?
The last program year will be for 2021, and that will, you need to make sure, so as we're, Access is approving these attestations, and they open up for program year 2020 and 2021 in the next couple of months, the providers will want to be on top of the testing because there will be, CMS is providing a kind of a quick turnaround with as the program ends. So your last year to attest is going to be program year 2021.
Okay, and Priscilla, what is the start date for the attestation for program year 2020?
So we are, Access is estimating, Caroline Denny can speak more to this if she wants. Access is estimating to open attestations for program year 2020 to the beginning of 2021. And there will be an email sent out from the prepayment Access team alerting the providers that they are opening attestation for that year. So the person who had that question, if there is some contact information in my presentation that will be sent out, and let me pull that back up, if you want to put on the email chain to receive that information for when attestations are opening up and everything, you can contact the EHR incentive payments at azaccess.gov and actually put on their monthly email for that information for when it officially opens.
Oh, okay. I did unmute Carolyn, so if she would like to chime in, she's welcome to do so. There was a follow-up question to, can you still attest if you are not required to attest?
So no providers are required to attest to this program. However, keep in mind that if you have received your first payment in 2016 or in a prior program year, then you are able to still attest in later program years. So I'm assuming that provider has received one payment at least. They are able to attest, but of course they're not required if they do not want to do the work to receive that money. We do encourage you to go ahead and do that because it is a significant amount of money helping these providers as you're taking care of Medicaid patients.
And Carolyn, did you want to add anything to that at all?
Sure. So everything that Priscilla said regarding the opening is accurate. We will also have the date posted within the EPIP system, so you don't have to, search and find. And we will also have the date posted on our website when 2020 is open and available for attesting.
Wonderful.
Thank you.
Follow-up question to that is also, if no payments have been received, is it possible to start?
Unfortunately, no, but I would advise that person who asked the question to go and make sure their provider hasn't received their first payment in another state. So one of the requirements of the program is a provider, your first payment is called an AIU payment. And if you receive that AIU payment in 2016 program year or a prior program year, you're able to attest to your second payment. However, CMS does not allow any providers to receive their first payment after program year 2016. But that provider they're potentially referring to could have received their first payment in another state. So I would advise them going and checking with that provider or with CMS to check into that to see if they have received a first payment already.
Thank you. Oh,
These are all great questions. Oh, go ahead.
The chat box is filling up here. That's wonderful. Thank you, everyone. The next question is, if a newly added provider in 2020 received their first payment at another practice, can that new provider attest in the current practice that they're in?
So I think there's twofold to this question. I may be understanding incorrectly, but I'm going to try to explain both sides of it. So a new provider in this program, they should not have been able to receive their first payment in 2020, but say they received their second payment in 2020 and then switched to a new practice, so they're new at that new practice, then that provider could not have received a second payment in 2020. You can only receive one payment each year for the provider. And so that provider can't get two payments in the same program year if they worked at two different practices. And let me know, whoever put that question in, if you want a follow-up question, please let us know, or I did not answer that correctly, let us know and we'll try to answer that and get you the answer you're looking for.
Yeah, Priscilla, can we add some clarification to that? So depending on the program year, this is Caroline, in which they receive that payment, if they receive that payment, let's say for program year 18 or 19, and they want to apply for program year 2020, then yes, they can apply with the new practice. So it doesn't matter which practice the provider is at, as long as they've received a prior payment, at least a minimum of one payment in the program, they would be able to come in and attest, providing that new year they have not previously received a payment for, obviously. So hopefully that helps.
Thank you, Caroline. Thank you for adding that clarification.
You're welcome.
And the person that asked the question did acknowledge that it did, they do understand. Yes, it does. Excuse me. So thank you.
Thanks, Christine. If anyone else has some questions, make sure to put those in the chat box. And I know we're hitting our time at the end, but there is the tip sheet, which is referenced in one of our previous bottom slides. There's a tip sheet that just goes through the documentation requirements. And there also is an FAQ that y'all can review and look through if you'll have any additional questions. And again, feel free to reach out to Access or Health Current with any questions you may have about this webinar or any other questions about the Promoting Interoperability program.
Wonderful. Thank you so much, Priscilla and Carolyn, for being able to answer our questions today. I know we are at the top of our hour, and we'll go ahead and just note these questions. So if there are additional follow-up from our participants today, I encourage you to use the email addresses to either reach out to Access directly or to Health Current, and those questions can be answered for you regarding the program. Any other last minute takeaways for Carolyn or Priscilla? If not, then again, thank you for joining us for today's webinar. Each of you that have registered and participated will receive a copy of the webinar slide deck, along with any Q&As that were addressed during the call. The call has been recorded and will be posted along with the Q&As to the Access and Health Current websites. This will conclude today's webinar. Thank you to Access for sponsoring the presentation today, and thank you for all of you that are participating. Stay safe and have a wonderful rest of your day. Take care.